Hello everyone, a very warm welcome to the part 3 video of adrenocortical disorder. Here we go through the congenital adrenal hyperplasia. First we go through the introduction, then the pathogenesis and what various pattern that can be seen in congenital adrenal hyperplasia, and what are the various features in relation to those patterns, and also we see the morphology of adrenal glands in this congenital adrenal hyperplasia. So let's begin with introduction. This is a heterogeneous autosomal recessive condition where there is a deficiency of enzymes that are involved in adrenal steroid biosynthesis, particularly cortisols. And this happened due to the mutation of the gene that results in the synthesis of these enzymes. And there is a reduced production of the cortisol due to the enzyme deficiency. So the feedback inhibition to the secretion of ACTH from the adrenal, pituitary, anterior pituitary, that will be lost. That means this feedback inhibition will be lost, and in the absence of this feedback inhibition, the secretion of ACTH will be increased. So this increased ACTH result in adrenal hyperplasia and also results in increased production of the cortisol precursor steroids, and these cortisol precursor steroids are then get channelized to the production of androgens, and that results in the increased virilizing activity. And if this enzyme deficiency also affect the aldosterone secretion from the zona glomerulosa, then that present with salt loss, and those patient in addition to virilizing syndrome present with the salt loss. And the most common enzyme deficiency is uh, 21 hydroxylase deficiency, which accounts for 90% of cases. And based on the nature of the nature and this severity of the mutation in the cytochrome P21A2, the three patterns can be appreciated in congenital adrenal hyperplasia due to the 21 hydroxylase deficiency. Those patterns are like salt wasting adrenogenitalism, which is called as classic adrenogenitalism. Here, the 21 hydroxylase deficiency will be severe. That means there is a complete loss of 21 hydroxylase, and due to this loss, the aldosterone synthesis will not occur, and that results in a salt loss, and also the blood volume will be reduced, and the person will be more predisposed to hypotension, and the risk of dehydration will also increase in salt wasting adrenogenitalism. Similarly, in simple virilizing adrenogenitalism, there is a partial deficiency of 21 hydroxylase due to less severe mutation of cytochrome P21A2. And also in non-classic adrenogenitalism, there is a very minor deficiency of 21 hydroxylase um, synthesis. 21 hydroxylase deficiency is very minor in non-classic adrenogenitalism. So these patients present with hirsutism, acne, and in female menstrual irregularities can be seen, which are very minor features. Here in the figure you can see that in the um, due to the mutation of the cytochrome P21A2, progesterone cannot be converted to 11 deoxycorticosteroid, and the aldosterone production or synthesis will be low. That results in a salt wasting congenital adrenal hyperplasia, and there will be the low blood pressure, and the risk of dehydration will be increased. And similarly, this mutation also results in reduced production of the cortisol, and this reduced cortisol level results in a loss of or absence of feedback inhibition to the ACTH secretion. So that ACTH secretion will be increased, and this results in the hyperplasia of adrenal cortex along with the all other part of the adrenal gland. And this feedback inhibition also results in reduced feedback inhibition results in increased ACTH production. So this ACTH stimulate the production of the progesterones and so many other precursors of this cortisol, but cortisol synthesis is reduced. So All these precursors will be channelized to the androgen productions, and these androgens will be increased, and this results in hyperandrogenism, that is virilization, menstrual cycle disturbances, and early epiphyseal closures, and results in the short stature of the person. And in salt wasting syndrome, you can see there is a total lack of 21 hydroxylase and inability to convert progesterone into deoxycorticosteroids that we discussed earlier, and there will be no synthesis of mineral corticoids, that is aldosterone, and there is a block in the conversion of hydroxyprogesterone into deoxycortisol, resulting in the deficient cortisol synthesis as well. And also there is a salt wasting, hyponatremia, and hyperkalemia, which include acidosis and hypotension, and also the cardiovascular collapse. And the block in the cortisol synthesis and excess production of androgen lead to the virilizations, and that can be recognized in female at birth or utero, but in male after the 5 to 15 days of the birth. Here you can see the cortisol is being utilized by the zona fasciculata, zona glomerulosa, and zona reticularis for the production of the cortisols, corticosterones, and aldosterones, and androstenedione. And there is a role of 21 hydroxylase in this synthesis of the hormones, and once there is a deficiency of those enzymes, then this hormone production will be reduced, that we discussed earlier. So let's see simple virilizing adrenogenital syndrome without salt wasting. Here this occurs in approximately one third of the patient with 21 hydroxylase deficiency, and these patients do not show the symptoms of the salt wasting like the hypotension, cardiovascular collapse, and the risk of dehydration is not seen in such patient, because the mineralocorticoids produced in a sufficient amount that can prevent the salt wasting crisis, and this lowered glucocorticoid levels fails to cause feedback inhibition to ACH secretion. Thus, the level of testosterone is increased, resulting in the progressive virilization. And in non-classic or late onset adrenal virilism, so we can see the only a partial deficiency of 21 hydroxylase, and this account for late onset, and patient may present with mild manifestation of hirsutism, acne, and menstrual irregularities. And non-classical congenital adrenal hyperplasia cannot be diagnosed on routine newborn screening. And in the morphology, we can see there is a sustained ACTS elevation due to absence of the feedback inhibition due to the low cortisol production. So there is a bilateral hyperplasia of the adrenal glands, and its weight increases to 10 to 15 times more than the normal weight, and the thickened and nodular adrenal cortex can be seen, and this widened or thickened cortex appears brown due to the lipid depletion, and the proliferating cells are mostly compact eosinophilic at the lipid depleted cells that is intermixed with the lipid laden clear cells. And so hyperplastic corticotropes cells can also be seen in anterior pituitary in most persons with congenital adrenal hyperplasia. And what clinical features that we can see are, the high levels of intraadrenal glucocorticoids are required for the synthesis of catecholamines in the adrenal medulla. But in this congenital adrenal hyperplasia, the level of cortisol is low, so we have seen that cortisol have permissive action on the beta adrenergic receptors as well, and also it has role in synthesis of catecholamines. So if the level of this cortisol will be low, then the synthesis of catecholamines will be compromised, and that results in adrenal medullary dysplasia. And due to that, there is a hypotension and circulatory collapse in the patient, and this occur especially in the severe salt wasting 21 hydroxylase deficiency. And in infants, this severe enzyme deficiency results in life threatening conditions like the vomiting, dehydration, and the salt wasting, which might be life threatening for the newborn. And effects of congenital adrenal hyperplasia on androgenic activity can be seen is that the precursors of this cortisol are channelized to the production or synthesis of the androgens, and that results in masculinization in females, like the clitoral hypertrophy, pseudohermaphroditisms in infants, and oligomenorrhea can also be seen in females, and also hirsutism, menstrual irregularities in post-pubertal females, and in males enlargement of the external genitalia, and oligospermia can also be seen in older males. And you can see there is acne and premature puberty and hirsutisms and menstrual irregularities, androgenic alopecia in the patient. So clinical features can be seen in the patient who are suffering from the congenital adrenal hyperplasia. Thank you very much for having patience.